All right. Good evening, everyone. We just wanted to thank you and welcome you all for joining us tonight. Dr. Coleman and I are expecting a very engaging and hopefully cathartic hour talking about something that torments all of us, surgical complications. So to start, Dr. Coleman and I would like to introduce our panel. My name is Julie Munoz, and I'm a shoulder elbow surgeon at the University of Miami and the Miami VA. And tonight, some amazing mentors and friends of mine have found this topic important enough to speak on their experiences as well. We have Dr. Bill Levine, who is the chairman and professor of orthopedic surgery at Columbia University and New York Presbyterian Columbia Medical Center in Manhattan. He's a shoulder elbow surgery expert who served as our president of the American Shoulder and Elbow Society. And he's utterly passionate about student, resident, and fellow education, surgical training, and career mentorship. Dr. Sheila Conway is a professor of orthopedic surgery and orthopedic oncology at Wake Forest, where she also serves as the vice chair of faculty development. These are somewhat new roles for her, as for over the past decade, she served as professor of orthopedic oncologic surgery at the University of Miami, where she was also the residency program director. She's a Resident Educator of the Year recipient and has also devoted a large part of her career to student, resident, and fellow education and mentorship. Dr. Heidi Allespach brings an amazing behavioral psychology perspective to tonight's discussion. As a clinical psychologist with expertise in behavioral medicine as it relates to physician wellness and stress management interventions, she served as a professor in the departments of family medicine, internal medicine, and surgery at the University of Miami for the past 2 decades. And she's devoted her career towards helping physicians stay mentally well enough to carry this burden, this load that we carry. So, Dr. Coleman, I'm going to hand the mic to you to introduce yourself and your panelist mentor, Dr. Laura Phieffer.
Good evening, everyone. My name is Lisa Coleman. I am a PGY2 surgery resident at St. Barnabas in the Bronx, and I'm here to introduce my mentor, Dr. Laura Phieffer. She is the Associate Professor and Director of the Division of Orthopedic Trauma and Preoperative Medical Director at The Ohio State University. She's done a lot of groundbreaking research, especially in the geriatrics field, relating to minimally invasive techniques and procedures. And she's also just been an amazing mentor to especially the female population at OSU, especially with relating to being able to show us that we can become phenomenal surgeons at the same time, live a well-balanced life, and just become a good person as a whole. So thank you everyone so much for joining us on this webinar of coping with complications. We're going to get started with a really rich discussion. Dr. Munoz is going to start us off.
Thanks, Dr. Coleman. So we're going to dive right in, essentially with the scenario that we all dread, where you realize that a complication has occurred with one of your patients. And we're going to keep it pretty specific to surgical complication. And so my question to the panel, and we'll kind of go through each person's thoughts here. How do you go about deciding if you can tackle clinically treating this complication versus when you realize that you need to phone a friend or potentially even get a friend's hands involved? So how do you access any necessary collegial help to safely treat the patient through the complication if you felt like you needed assistance with it? So that's kind of our first discussion point. So maybe Dr. Levine, you could start us off with some thoughts, which maybe your thoughts also as a younger attending are different than a mid-career versus later career, but everything's pertinent tonight.
Well, first of all, thanks for hosting Drs. Coleman and Munoz and for inviting me to participate. It's nice to be here. I think this is it sounds like it's a straightforward question. It's obviously very multifaceted because it depends, I think, a lot on years in training, just at first blush. But that being said, my partner, Mike Vitale, has created a culture of safety in spine surgery that involves calling a friend immediately. It's in fact one of the checklist items to do, to break scrub, to go out, to call a friend, even in the operating room, if you run into certain situations, to make sure, and this is critical for young surgeons to think about, because it's the exact opposite of, oh my God, I have to do everything on my own. It's actually in the heat of the moment of a complication, and especially in spine surgery, you may not be able to actually think clearly right in the heat of the moment. And as we all know as surgeons, one of the biggest problems is that complication begets more complication. Because if you then are rushing, or you're fearful, or you're anxious, you may actually create a second, more dangerous complication or problem than the initial one. So Dr. Vitale has created this checklist that says break scrub, go call a friend, a senior partner, a partner, whomever. And that happens. And at Columbia, they talk about it during our M&Ms quite a bit. Mike Vitale will break scrub. He'll go call Larry Lenke. Not a bad person to be able to call if you're a spine surgeon. But the point is, it teaches the residents and the junior faculty, wow, Mike Vitale is a world-renowned pediatric scoliosis surgeon, and he's breaking scrub and just making sure that his thought process is correct. Take a breath, then go back in and take care of it. So that's obviously a very in the heat of the moment, but I think that's a good example, Julie. I don't know if you want me to go further than that, but I thought that's a good place to start.
That's
Yeah.
wonderful modeling for the residents. I just want to say that. I love that.
Yeah, let's that's huge, because it's certainly not, just as you said. I think as a young attending, there is a lot of a burden to feel like you can do everything on your own, which is really, it makes no sense actually, but for some reason that tends to be the way that we think. Let's move along the panel, and then as we kind of continue through the evening, we can come back to other thoughts about all these topics really. But Dr. Phieffer, any thoughts and or anything that comes to mind from what Dr. Levine was mentioning?
Again, thank you, guys, for inviting me to participate. This is a really important discussion. I'm now in the more senior category, having been in practice for 21 years. And I definitely, the first 5 years of my practice, it was a much different place than what I am now. I am grateful. My subspecialty is orthopedic trauma, and I'm grateful that trauma, the way that I was trained at my residency program and my fellowship, we always start the day with fracture conference. We're talking about cases, and it's a very team-based approach. So I think in my subspecialty, it is we are more likely to phone a friend and call. But I love that idea, because I know that my other more elective practice, it is definitely more individualized, and you don't have the awareness per se of what everybody else is doing. And so I had great mentors. And I remember in my first 3 years of practice, I was on my phone to my fellowship director, and I reviewed so much about surgery. And I think the other thing is sometimes you'll run into complications in the OR. That's one moment. The other one is when everything went well in surgery, the patient goes away, they come to clinic, you look at the x-ray and you say, or, you're like, this isn't right. And you're in that moment in front of the patient face to face. And that is a very humbling place to be. And my only words of wisdom is to be transparent with your patients, and never try to gloss it over or put your head in the sand like it didn't happen. And I saw my mentors do that, and so that's the way I practice, and I'm very grateful for having that advice. But I think that sometimes is a kind of a different type of stress level. Usually you look at the x-rays before you go in and see the patient, so you have a little bit of space to prepare yourself. But that's the only thing, transparency. And you could always call someone before you walk in to say, all right, what are going to be my next steps?
Absolutely. Dr. Conway, can you share your thoughts?
Thanks for having me on the panel. Great input so far. I have to say, I agree with everything that's been said. I am an oncologist, so much like what Dr. Phieffer was saying, coming from like a team-based approach, from preoperatively helps, I think, when you need to engage for help. So, having a sarcoma conference and having other people's opinions, I think that helps, in your preoperative decision making, but also makes you more comfortable reaching out and asking for people's advice, opinions, and help when things don't go as you would like. So, sort of forging those friendships early before you have the complications is helpful. I think finding those people whose clinical judgment you trust is critical. You can ask anyone for help about these kinds of things, but it's a very personal moment. Your first complication is often emotionally very difficult. So I think, knowing those people you can trust when this comes up is critical. And if you do have to step away from the OR, kind of knowing who to call. And that does happen more often than you'd think. And I do think it's a nice thing to model. As doctors, we don't ever know everything. We are always learning. And to model anything differently to residents, students, anyone in the room with us, I think is not modeling reality. So if you're having a hard time, if things aren't going the way you are, engage the team. If you need to step away, do what you need to do to take care of your patient. Most things don't have to be, there are very few complications that are like the house is on fire. So if the house isn't on fire, get things under control, get yourself under control, assess the situation, get the information you need, and be logical. And do whatever you need to do for yourself to get yourself in that space. And Heidi can speak to some of those techniques, but it's different for everyone. But developing such techniques for yourself when you're in the moment, if you're having a hard conversation with a patient, if the patient's in conflict with you and you don't want to get elevated or escalated, there's all kinds of techniques that you need to learn to sort of keep yourself even, tempered, and controlled in these, what are very difficult situations for every physician.
Absolutely. And in just a moment, we're going to talk about that patient-physician relationship specifically, which obviously gets tested in these moments of complications. But I just wanted to highlight something that you said there, because it was minimized, but it's super important, especially for early career people. Getting to know your colleagues when you first start your job and being friendly and it's intimidating sometimes starting a job. And so sometimes you sort of feel like, I'm in my little bubble here. I just want to keep my head down, prove that I do good work. But it's huge to meet the rest of your department, particularly the people that are doing similar types of surgeries that you are going to be doing. Because those are the people that you're going to call when you're having an issue that you need some advice on. So if you've really spent like a year or two sort of isolating yourself or feeling awkward or not knowing how to integrate yourself into, either a big academic department, or maybe it's a big multi-specialty group, or, maybe it's a little group, maybe it's just you and one senior partner that just seems like an intimidating father, maybe mother figure. It behooves you to sort of go out on a limb and get friendly as quickly as you can, because it'll help you feel like you aren't alone when that first bad thing happens. So that spoke to me there, Dr. Conway. We're going to move to the next question, and I'm going to ask Dr. Allespach to kind of head it off, because it's kind of just what Dr. Conway was mentioning. So at this point, we're going to assume you've had this complication. You've either realized that you've been able to work through it, or you've had a colleague help you work through it. And so as that clinical process is moving forward, what tools do each of you use to maintain a trusting patient-physician relationship? Because obviously, like I said, this is when it gets stressed. So Dr. Allespach, any thoughts?
So, in the older days, I remember I've been around long enough where, if you make a mistake or if there's complications or something happens, you don't say, you don't admit it, right? And Nowadays, that's different. And like Dr. Phieffer was saying, the transparency, I think, being honest, being transparent, not blaming. A lot of times, underneath anger is fear. And a lot of times, when we feel we're being blamed for something, or we feel like we are to blame for something, it can come out as anger because we're afraid. And so we get defensive. So not being defensive, being collaborative, collaborative disclosure, where, maybe anesthesia and surgeon both talk to the patient at the same time, and just being really upfront with what happened and what the plan will be, is sort of the way to go with that. There's a wonderful article in AMA Journal of Ethics. It's called "What Constitutes Effective Team Communication After an Error," by Hart and colleagues in 2020, and it goes into detail about sort of, what to do if there is an error or if there's a complication, bad outcome, and how you can restore trust with patients. So I highly recommend reading the article.
Thank you. I think we'll be able to send that out. We can gather some of these resources and send
Sure.
those things. Let's mix it up. Dr. Phieffer, what are your thoughts here?
So I model my practice over the mentors that I felt had great relationships with patients, and it really is based on being transparent from the beginning. And so and one of the things, and I'm in an academic practice, so we also benefit, and one of my I always tell the residents, you can learn the most sometimes from M&M, because we really want to share amongst our groups where, we as surgeons could have, looking back, could have done something differently or better. We really want to be self-reflective to try to avoid any other future patient harm. So I like learning from others so that I don't make those mistakes. But I think when I first hear trainees, when they're presenting something or they see something in follow-up, and there is this, blame the patient was non-compliant. So maybe there is some component of it, but I always think it's important for us as surgeons to make sure what could we have done different. And so the patients are not going to for me, for fracture fixation, if we have a fracture fixation, the fixation fails, the wrong thing to do with the patient is say you walked on it too early. But you can look at it and say, well, maybe I didn't put the right, biomechanically put strong enough to allow for, a weight bearing. But it's having that open conversation with the patient. And when you're talking about the next steps, you can engage them and say, let me partner with you when we have to do this next stage. Do you believe that we can really maintain non-weight bearing, or, whatever the case may be? But I think the key is transparency and explaining things. So taking, whether it's images or a model, and explain to them what happened. I think patients are very forgiving if they think that you're going to care about them and help, guide them through what the next step. They're really very rarely, or I've been grateful, I haven't had patients who demanded that things had to be perfect. I'm sure that probably in some of the elective surgical practices, there may be a different perspective. I get patients who are already broken. But I think for me, what has been the best is to educate the patient, be transparent, and just simply care for them, right? I feel okay, right, to say, I am sorry that this happened, but we're going to get through it. And so that's been my strategy so far, and it was built off of just really some fantastic mentors who had great patient relationships.
Yeah, I mean, that was awesome. There's so much in there. There's, you know, you describe explaining to patients so that they don't feel like they're in the dark in what's otherwise already an emotionally charged and scary situation for a patient. You know, turning something that maybe we'd want to throw some blame on because yes, like, why are you walking on my great, you know, whatever, pelon. But instead of being like, you walked on it, you kind of turn it into a, okay, let's do a sort of a team plan of next time. When are we going to start walking on it? You know, which I think is huge. It makes a patient not feel like you're yelling at them, but being like, oh yeah, I got to get involved in this and understand this better, which I think can really diffuse situations. And then there was so much more in there too, but those were the two ones that stood out. Dr. Who ended? Dr. Conway. We won't have you. I don't want you to end every single one. Dr. Conway.
Or yeah, a lot of that resonated with me. I don't want to repeat things. I think the transparency piece, just remember it begins with the pre-op conversation. Coming from a field where it's almost impossible to explain to a patient everything that could possibly go wrong with a big oncologic procedure. So that's not a realistic expectation. But you do want to go through the major complications with your patient. And I remember when I first started, I was like afraid of scaring my patients off. And so you almost want to sugarcoat it. But I think being really clear with them about the things that can go wrong and then comforting them, you know, that you do everything in your power to minimize the risk of these things. And then if you've had that conversation with them, then if a complication happens, it's not like, what? There was a nerve there? I didn't even know there was a nerve. You know, you don't want them to feel like they're completely out of the lane when a complication happens. And it really is possible, especially with obscure complications. So, but for the routine ones, I think you can prep your patients, especially for elective practice. You know, there's probably, you know, top 3, top 5 that you should go through with your patients, and have that conversation with them. And that will lay the crepe for the hard conversation, which is when the complication happens. And then just for any difficult conversation, I think all of this has sort of been hit on, but have a plan. Be self-critical, look at the complication, do your research, talk to your friends, figure out what you think needs to be done. And when you go to the patient, have a plan. You know, some things we have more options for than others. You know, if it's a death or a loss of limb, you know, you might not feel like there's anything you can do as a surgeon, but that's not true. You can start by being kind, by being clear and concise with them so that they understand what's happened, and then that you're there for them. And then you can talk with the plan. And that might just be, you might be getting them to a different doctor. It might be going to hospice in my case, but make it clear to them that you're with them, that you're still with them, that you're with them through this, and that whatever the next step is, like, you're their doctor. And that makes a huge, huge difference to people. They don't feel abandoned. And a lot of times you do have to refer to other people, or you do need to reach out for help, or you do have to maybe transfer care. But you should do that with kindness and compassion, and with them understanding, like, you're not abandoning them, you're there for them, you know, and you're going to walk them through whatever needs to be done.
Yeah. And I have some colleagues that have had situations like that too, where they, if you are no longer caring for the patient, you can still even check in with families, which goes a long way, to what you were speaking about, not abandoning the patient, not abandoning the family, even if they're not fully in the same level of care, you know, with you and your team. So that's important. Thank you. Dr. Levine, the caboose on this one.
Well, there's two things I want to highlight, some of it tying in a lot of the great principles and thoughts by the other folks on the panel. The first is death. What does that mean? Well, since I was started in practice, I had a consent form, my pre-op conversation with patients, which say there's 2 kinds of complications. One we call catastrophic complications, and that includes infection, nerve injury, and anesthetic complications, including death, and then all of the procedure specific things. And some of my friends would say, why on God's earth would you ever talk about death in this? And I've always done it, and I've done it just not to scare people, but just to kind of level set that we're walking into an operating room. And I don't care if it's a 10-minute knee scope or if it's a 12-hour Conway special, this is real stuff and it's serious. So that's just something that's been part of I've never scared a patient away, but I've always done that. And I think it's important for people to hear that. The second thing is tying into what Sheila was just hinting at or talking about is I'm going to quote Sheryl Sandberg in her book, Lean In. And the biggest mistake surgeons make, doctors make as well in general, but the biggest mistake is that they run away from all of a sudden they don't want to answer the patient's questions, or they don't answer the phone, or they have multiple unreturned messages. And it's a common defense mechanism. We understand why it might happen, but it's the worst thing you can do. Now, whether the patient sues us or not is not the reason to lean in. The reason to lean in is it's the right thing to do for your patient. The byproduct often is that the patient will have more respect for you and maybe less chance of suing you. That is true, because they might feel that you're actually taking ownership for it or what have you. So as hard as it is to have that complication, that is the patient you spend more time with. That is the patient you answer more questions on. That is the patient you call more often, all of the above. And again, because it's good patient care is first and foremost for why you're doing that. But it does have, I think, a positive trickle-down effect in how your relationship will go with that patient. And I'll tell you, as doing this a long time, complications are hard. Somebody once said, if you say you have no complications, you're either a liar or you're not operating enough. So it's also important to recognize that every single one of us, no matter how gifted a surgeon, will have complications. So coming up with a strategy for how you deal with it is really critical. And when you're young in practice, it can be devastating on the one hand. On the other hand, taking some of the tips you're going to hear tonight, I think will be helpful to have you be able to figure out how to navigate not only that patient's complication, but the next patient, because there'll be another one at some point in the future.
And to that end, these patients take more long to speak to, particularly in clinic. And one very simple trick that I've found over the years is if they can accommodate, that patient is the last patient before lunch or the last patient of the day. Like if you have to spend a solid 2 hours, with these patients, that you do it in a manner where you're relaxed and the patient doesn't feel like they're getting rushed in a triple booked slot. So be mindful of that if you have any ability to see your clinics ahead of time. Dr. Coleman.
All right. This has been such a great talk. Thank you, everyone. So we're going to move on to the second part of our webinar, and we're going to take more of a look introspectively. I like what Dr. Levine was saying about that you need to come up with a strategy to dealing with complications, because it's not a matter of if you're going to have a complication, it's just a matter of when, especially if you're doing a lot of procedures. And so I think it's important for you to not only come up with a strategy of dealing with how to navigate the process with the patients, but you also have to navigate the process of yourself dealing with the complications. A complication is like touching fire. What are you going to do about it? And so my first question to you all is, how do you process your feelings of guilt and or shame or any other negative feelings after having a complication, especially after you've worked really hard to obtain the skills and experience you have? And since Dr. Levine gave me the idea of asking this question, we'll start with him.
Well, I think it's a really it's a poignant question, and it's something that I think for all of us who have, we teach our residents and fellows and students to debrief after every case, whether it went well, whether it didn't go well, whether it was in the middle. And that's part of the training that Chris Ahmad, my partner and good friend, has really taken to a whole different level. How can you take a case and and dissect it down to the millimeter of where you placed the retractor and why you did it in that particular place. So that's, I think, having that as part of your culture helps you really manage the complications, because it's part of your normal process to say, I'm going to sit down after this case and understand what went great, but what I could do better next time. I'm also going to look at a complication in the same light. I'm going to say, why did that complication happen? Was it something that was I rushing because I'm, running 2 rooms? Was I, letting the resident take part of the case, and I, at that particular time, probably should have had more responsibility in participating? Whatever it is, whatever the reason, you try to understand and learn from it. I'll give you a real life example. I'm doing a revision case about a month ago. Patient had an ORIF of a proximal humerus fracture that went terrible, and I had to convert her to a reverse shoulder replacement. And so I do the surgery and I put the prosthesis down. It was a complicated part. I said to the fellow, I'm going to do this part. And I put it down and it looked perfect. I didn't get an x-ray intraoperatively. I ranged the shoulder. It was awesome. High five. Let's go. Post-op recovery room x-ray, humeral stem out of the humeral canal. It had found the pathway through one of the holes, and there was a lateral breach of the cortex that I just didn't appreciate. The prosthesis looked perfect, but the stem was out. Talked to the patient, talked to her husband. She was still under anesthesia, still had the block. We went right back to the operating room, did the procedure, obviously put the humerus in the right spot. Now, felt horrible. Talked to the patient immediately, talked to the husband immediately. Patient loves me still, thank God. And she's had no ill effects from it, had a second anesthesia, but we made sure that we did everything after that from a patient quality and safety perspective. No extra bills, nothing to, get her frustrated, angry, or whatever, to say, listen, this complication happened. I owned it. We took care of it. But boy, that was really, an opportunity for me to say, this is terrible. But we had to deal with it in the moment, address it, and move forward. And I think she appreciated, and her husband appreciated, obviously the honesty with how we approached it and why we did what we did. And she asked several times, how did it happen? Why did it happen? And I just was as transparent as I just was. I said, you know what? There was a breach in the bone. I didn't see it. It didn't look like there was. And the x-ray showed me. So.
Thank you, Dr. Levine. Dr. Conway, can we hear your thoughts?
Certainly. Yeah, complications are rough. And I will tell you that early in my career, I did not have the tools to manage them effectively. I lost a lot of sleep, had a lot of sleepless nights, kind of carried it around with me. Fortunately, I have learned for myself, just like Dr. Levine was just explaining, if you take a pragmatic approach to your complications and are proactive about them, it's empowering. And you can often intervene in a positive way. Sometimes you can fix the complication, but most of all, you can control how that situation goes from there on out if you're involved. If you're not involved, then many other things can happen. So my approach is self-reflection, critical evaluation, what went wrong, what could I have done differently, just like Dr. Levine was explaining. And then, I try and think of something practical that I can do in the future to prevent that from happening again. So, maybe it's a teaching thing, or if it's, you need to put a new retractor somewhere, or I try and learn and improve my practice based on that complication. And then I try and let it go. I try and do the analysis, incorporate it, and then I actively try to let it go. Because you know, beating yourself up about something like that, you know, is just self-destructive, I think, beyond that point. So again, techniques, like I can perseverate on things. I can, it's something I do. And you know, if you have a bad complication, pretty easy to get in a loop. So I meditate, I do yoga, I do puzzles, I do games, I do things that keep my mind from focusing on that negativity and redirecting it. And to be honest with you, like it works. If you start doing it and you practice it, it actually works. Like I can manage these, you know, horrible outcomes happen in my field, and they will always happen. People die, people lose legs, things don't always go as I would like. I have horrible conversations every day, but like I'm not crying about it at night. That's a big difference. So, you know, getting those skills and doing that earlier in your career, or getting, you know, getting those rhythms down, will just benefit your mental health dramatically.
Thank you, Dr. Conway. You should write a book for residents because those are very healthy ways to go. Dr. Phieffer, can we hear your thoughts?
So I just want to echo, I really like what Dr. Conway said about actively addressing it, because what I will say, no matter where you are in a career, if there's a complication and you realize there's something that maybe that you could have done differently, it is a gut punch, because we all go in, we all prepare, we all go in to have, you know, the best outcome for the patients, and you get to know the patients. And so it's a real gut punch. So it's something that if you try to bury it, it doesn't go away. And so I love that idea of just actively. I will say, just like what Dr. Levine mentioned, it's not if, it's when you will have your first complication. And what is so helpful is to speak to people, speak to your resident, you know, colleagues who, you know, if you're resident, your resident colleagues in faculty, but like when you graduate, you could still call. They're going to be some of the people who, you know, you stay close with the rest of your life. You call your former program director, or your, you know, a mentor you had in medical school, or, you know, if you're lucky, you know, your partners you're close with, but talk about it, because it really helps. And then when you see other colleagues go through this, I dearly respect a young spine surgeon. Spine is a really stressful, especially if you're dealing with major, and he had a young person who had a death because of an aortic tear, and they did all the right care planning. They had the vascular surgeon there, but the patient died, and it was impactful because the patient was a father, and I knew deep down how much he was hurting. And what was helpful for me and other faculty, we just said, hey, listen, you know, we've been there. This is awful. You will get through this. And he really appreciated that. And so just knowing that if you do that, and then others will do that to you, but we have to talk about it, because if you don't, it will really tear you up. So that I like that idea of actively, you know, addressing it.
Thank you, Dr. Phieffer. Yes, there have been a lot of really great advice. We love how your experience has allowed you to develop these very healthy and impactful ways of dealing with complications. And so I just want to hear from Dr. Allespach. What about those people who, you know, aren't as strong or positive willed as our lovely panelists? And, you know, we have orthopedic surgeons who are isolated. They don't have the same mentorship available or resources to be able to process things in a more healthy way. What is your take on this from their perspective?
Well, that's a good question. Well, if I may, first, I just want to give a shout out to my co-panelists, because I'm so impressed with everything you all said. I mean, from Dr. Levine, you know, talking about creating a culture and you know, and the transparency and accountability, and then Dr. Conway with talking about, you know, embracing, you know, the fact that you're going to have complications and developing, coping strategies that you've individualized for yourself that are really effective. And then, Dr. Phieffer with the talking about it is so important. I'm going to come to your question, Dr. Coleman. I want to read a quote real quick. First of all, there's a wonderful, wonderful book that I want to give a big shout out to as well, for all the attendees as well as my co-panelists. And it's by Surgeon Atul Gawande, who's a wonderful writer.
Mhm.
And it's called Complications, A Surgeon's Notes on an Imperfect Science. Wonderful book.
Yep.
Wonderful book. It should be required reading for all residents, I think, surgical residents. And then David Levy, in his book, he's a neurosurgeon, in his book, Gray Matter, he says, "It is never easy making decisions in matters concerning life and limb. Patients rarely know how a doctor suffers when injury happens because of a medical or surgical intervention." And, Dr. Coleman, in answer to your question, for those surgeons who are isolated, it's so important to if they don't have colleagues to speak, because we saw with the pandemic, there's a big difference between isolation and solitude. And isolation, as someone was saying, I think Dr. Phieffer, it will eat at you. It will tear you apart from the inside out. And so it's so important to be able to connect with others, to share, and to realize that you're not alone. As a non-surgeon, I cannot imagine how difficult that would be to have a complication. And so it's so important. So, for those surgeons who are isolated, I think getting a book like Atul Gawande's book on complications, to realize they're not alone, and then to learn some of the things that we started. So the initial question was, how do you handle the feelings of guilt and shame and anxiety and, self-doubt? 1 in 4 physicians have imposter syndrome. And so, they already have a lot of self-doubt. And so when there's a complication, among surgical residents, it's very high. And so when there's a complication, it's sort of just like serves, yeah, I shouldn't be doing, I shouldn't be operating. I'm a fraud. I'm not good enough. I shouldn't be doing this. And I've actually talked to a lot of residents who thought about quitting. We started something called Complications Small Groups at University of Miami several years ago. We need to pick that up again this coming summer when Grand Rounds is put on hold. And we had the PGY levels all split into different groups. And the PGY 1s and 2s, we would meet with a chief resident and me, and they didn't really have any OR experience yet. So it turned into sort of a support group, like, how do you get through the difficult rotations and how do you get through being an intern? But for the 3s, 4s, and 5s, I had a surgical attending with me, and he shared, he became very vulnerable and shared, about how he would lose weight and all this other stuff. And it allowed the residents then, kind of like what Dr. Levine was talking about with modeling, it allowed, by him being vulnerable, allowed the residents to then talk about their fears, and to gain support. And so that's called being a warm line, WARM line. When we share our vulnerabilities with our learners, it gives them permission to be vulnerable. So the other thing I wanted to say in terms of what Dr. Phieffer was saying about M&M being so important, and it absolutely is, maybe also consider something that we like to call vitality rounds, which is the opposite of M&M, where residents present cases that went really well, and they get to kind of like show off a little bit, feel good about it, and say, wow, this was a really tough case, but our team did this and that and the other thing, and we didn't have complications, and this went really well, right? So these are the kinds of things. But I think normalizing the feelings, and for people who are isolated as well as for people who are really connected, normalizing you're not alone. this happens to everyone, as Dr. Conway was saying, and that, the most important thing is to learn from it, right? And all of this, when you look back, and I think many of you might agree with this, as we get older and we look back, it's the pain as well as the joy that makes us into the professionals as well as the women and men, that we're meant to be, right? And so, anyway, sorry for that long dissertation.
That was awesome, Dr. Allespach. And I just wanted to chime in because you used the word a couple of times, vulnerability, but I can't say it enough. You will feel better the sooner you get comfortable being vulnerable with other people. I mean, clearly it needs to be somebody you trust, preferably someone that's kind. But there's no other way. There's no other way with anything uncomfortable in your life, whether it's family related, illness, complication, work, whatever. If you try to pretend like you are a man or woman made of stone, you will just kind of get eaten alive. So get comfy, feeling vulnerable, feeling silly, being like, I'm going to give you a call and bare my soul right now. Something bad happened in the operating room. You'll start to feel better that very night. I can pretty much guarantee anyone listening to this that. So thank you for bringing that point up.
Can I add something to that? I think, hold on to your mentors and those people that you work with, that you emulate and that you trust. Many of those people are on the panel with me today. I've turned to Heidi under many different circumstances, both professional and personal, and she has been a great strength to me. So, when you find those people, cultivate those relationships, stay in touch with them. I'm sure Dr. Levine has people calling him all the time for advice. Residents, or text me or call me about cases, that I haven't talked to in, 10, 15 years, but they feel comfortable, they feel confident that, I'm going to give them an honest opinion. So when you have those relationships, hold on to them and cultivate them. And, sometimes your best resource isn't in your, back right next door, isn't your direct partner, but, you have resources all over, and do not hesitate to lean on them when you need them.
We have actually an excellent question here from another friend and mentor of mine listening, Dr. Kat Burns. I'm going to read it and see what the panel's thoughts are on this, because it's a very particular situation. We've sort of been talking a lot about how you use your tribe of people to kind of help you get through this. But what are your suggestions for surgeons who have been sued? Because this is often far after the complication is clinically resolved. There are still lots of after effects. What's the best way to handle the stress, anxiety, shame, and guilt involved? Advice that at that point, you might not be able to share things, you might not be able to discuss things, or seek input because of legal discoverability and whatnot. I didn't paraphrase that perfectly, but hopefully you guys get the gist of what we're asking here, which is, how do you do this in a legal situation and still not go out of your mind?
I'm happy to start if you'd like, since I've got the most gray hair and probably been sued more than anyone else. Thankfully, I haven't been sued that much, but I did have a 2-hour meeting with an attorney today about a case that is pending. So I can't say anything about the specifics, of course. I think it's the hardest part. Sharing complications, as we've kind of alluded to tonight, can be challenging without the angle of legal implications. You have to do all the things you just suggested, Julie, which I think are really helpful advice. And reaching out to friends, as we've talked about, is really important. When it's a legal situation, however, the kind of everything changes a bit, because now if you have a conversation with a partner or have a conversation with, somebody where it could be brought in as evidence, that's potentially problematic. So you have to have a narrow I think you have a scope of the cone of silence, and it might be a loved one, it might be someone that you just share kind of generalities about it, but more so not the specifics of the case, but kind of how you're feeling. We talk about leadership being very lonely, and when you are sued, it is super lonely because you feel like, oh my gosh, I'm the only person that this is happening to. You question your very being as a surgeon, as a doctor. Like, oh my gosh, I did something so terrible that this person is, saying that I'm terrible and awful and horrible. An attorney said to me that complications are just that. They are not malpractice. Complications occur. Whether it becomes malpractice or not is a whole different discussion, and obviously the legal system will help navigate that. But simply having a complication, and it can be a very serious complication, still does not mean it's negligent and still does not mean it's malpractice. And you know what? If it turns out to be, then the legal system will actually do what it's supposed to do, and you will go on and recognize that, okay, I'm going to be okay with this. I think having a loved one, a partner, somebody to share the emotional, not the actual tactical or specifics, is my advice to people to navigate those feelings of insecurity, those feelings of guilt and shame, those feelings of imposter syndrome, as Dr. Allespach just mentioned.
Thank you.
I agree with everything Dr. Levine said, 100%. And I have found, I may not have as many gray hairs as you do, Dr. Levine, but that's just because, I have a good hairdresser. But, and I've never been sued, but, I stopped practice. I always tell people I'm not a normal psychologist, but if you know any psychologists, none of us are normal. But the reason I say that is because I talk to residents and fellows, and that's what I do, informally and confidentially. But it's so, I have found that as long as I take care of myself and walk through my fear about whatever it is, everything else is okay. Smart people think too much. The more we think, the worse we feel, and we can come up with all kinds of things, big things, big scary things. And the fear of the fear is usually a lot worse. So if someone is feeling terrified, and if someone is having those feelings of like, I'm so alone and I'm the worst surgeon in the world and I shouldn't be operating, which are actually very common feelings, since so many folks have imposter syndrome. It's so important to talk about those, as you said, with a trusted other, and not to hold all that in, because again, it will eat you from the inside out, and you go spiral into a depression, and our thoughts create our feelings. So the more I'm beating myself up, the more depressed I'm going to become. And when the truth is what you said, Dr. Levine, the complications are not medical malpractice. And even if it is, you're going to be okay. It's not like you meant to do something wrong. It's intentionally, and it all works out. I know people who have been sued. I know people who have, had malpractice cases, and they're fine. So anyway, I just wanted to say that. Always put yourself first and take care of yourself. And if you're scared and you're hurting, talk to somebody about it and push the fear away. Talk to a trusted person about it.
That's something that Heidi has definitely taught me, is that, whether it's you're getting sued or you're just having a hard time or having a hard time with a partner, or if there's a patient complication or whatever it is that you're struggling with, like, if you don't take the time to take care of yourself, like, you can't take care of your patient. And that's not selfish. It's not indulgent. It is required work. To being a good doctor, and she's really taught me that, and taught a lot of residents and fellows that she's helped with over the years. And I think it's a really, really important message.
Well, I just want to say thank you everyone so much for answering all of our questions so thoughtfully and thoroughly. And I love all of the themes of building community when it comes to dealing with complications and, you know, the character building moments of our lives when it comes to surgery. And so we wanted to put together a proposal for everyone. Addressing complications is a very important topic, and learning from these character building moments is very paramount to becoming a great surgeon, which is why we set up this webinar. We wanted it to serve as a starting point for a special educational series we would like to develop. We're still workshopping the name for something more catchy, but we currently are dubbing it the Anonymous M&M. And just like what Dr. Phieffer was saying earlier, an M&M is a phenomenal way to learn about surgery in general. For all of those who don't know what an M&M is, it stands for morbidity and mortality, and it's an education session where cases with specifically complications are presented and critiqued by colleagues. M&Ms can be a great source of gathering knowledge, but it's also a great source of anxiety. And sometimes it can be discouraging, and it can worsen those feelings of shame and guilt because you're being publicly picked apart. So what we wanted to do was create a space where we can have the benefits of an M&M without feeling that public embarrassment. So what we want to do is have physicians submit their cases to us, along with any burning questions that they wish to ask about the case. Because sometimes when you're under scrutiny, it's hard to have courage to ask some of those hard questions. Sometimes people will think, well, that's a stupid question. They'll think that I'm not smart, or I'm an attending now, I should know this, or they just don't know the best way of expressing themselves about the case. So we would have them submit. We, as the presenters, would present the case for them, and at an anonymous M&M, they wouldn't know who is who. And then we'll have a panel of experts to answer the submitted questions and also offer their expert advice. So in addition to getting a lot of the, you know, me too, I've had this moment too, and, you know, having those questions answered, we're hoping that this will also open up educational opportunities to other hospital settings who don't get to experience educational sessions like the M&M. And we want to be able to let everyone have access to these type of learning opportunities, no matter what setting they're in, so that everyone can continue to grow and become the best surgeons they can be. And so this is what this community has to look forward to. We hope that this idea can make better surgeons and create a more positive change in our community. So thank you everyone so much for your input in this question, in the questions. Dr. Munoz, do you have any other comments?
No, I'm just I'm excited about the possibility of running a series like that. We'll probably send some follow-up surveys and questioning to see how we would model it. And, you know, if there's interest, if it would be something that could be helpful to people. I do hear a lot from some of my friends that are out in the private practice world that they're jealous that I get to sit in an M&M in academia, because it's probably one of the most profound things about our profession, and something that very few other professions do, particularly high stakes ones. So I think definitely take it for granted when you're a resident, and then some physicians are really missing it out in the community. So I would love parting words of wisdom and thoughts from these experts, though. Can we do that? Can everybody do maybe 30 seconds of, I don't know, whatever the most important thing is you think somebody should take from this topic tonight? Start. We're going to do right from the beginning. Oh, no, I saw a hand, Dr. Phieffer.
Sure. I could just say is I hope everyone hears is that you're not alone, and to communicate, speak to someone, even if you're being sued. You don't have to talk about necessarily specifics, but just have that conversation. Don't isolate. So it's tough. Everyone, even your most revered, you know, colleague, they have complications too. So yeah, just That's my parting words of wisdom.
Dr. Conway?
Take care of yourself, be kind to yourself first. Be self-critical, but don't destroy yourself. Learn from your mistakes and move on. Really cultivate those relationships, professional and personal, that keep you centered and that help you, in your professional world. And people like Julie, who I can just pick up the phone and talk to anytime about anything. And it's a safe space. So, when you have those kind of people, keep them in your lives, because you're going to need them. You don't know when you're going to need them. And yeah, and just realize that it's a constant fluid process. You're never the best doctor you could be. You can always be a better doctor, and that's okay. It's part of the process. It's part of the fun. It's why it really doesn't get boring being a doctor. There's always a new challenge, and it's a great profession from that standpoint. So that was kind of all over the place, but those are my words.
Thank you. Dr. Levine?
I would, if I were summarizing this hour and what I would take away or hope people take away from it, number one, take care of the patient, no matter what, whatever that means. And number two, take care of yourself and make sure that you really focus on both of those. And those simple principles will hopefully stand you in good stead as you navigate surgical complications in your career.
Dr. Allespach?
You left me for last. I can't beat any of that. That was amazing from everyone. I mean, everything. You're not alone. And ask for help for the patient. And I think I'm one of the only non-surgeons on here. I am the only non-surgeon here, and I've worked with surgeons for many years, and I'm married to a surgeon. And I can tell you, and my grandfather was a surgeon, so I can tell you that y'all are really hard on yourselves. Really hard on yourselves. And so even when the operation's a success, you're still hard on yourselves. I could have done better, or I could have done. And so I think what I want to say too is start being a little more gentle with yourself. You can be gentle with yourself and still an amazing surgeon. So anyway, thank you so much for letting me be here. This was amazing. And I'm very honored to have served on this panel with all of you. You're all amazing.
Thank you for being here. Dr. Coleman, parting words of wisdom?
I guess the parting words of wisdom. I guess for all the residents out there, just remember that all the people who you train behind you are going to be a reflection of your leadership. And so if you want the residents coming up behind you to have these wonderful, healthy processing methods that you see these amazing attendings have, you have to practice them yourself. It's not easy, especially when you're a resident. You take a lot of L's, you take a lot of losses, and you get pretty beaten up. But if you're able to maintain your positive outlook, a positive way to process the emotions that come with just being a resident in general, then that means not only you are going to be a great attending to do that, but the people behind you are going to do that. And it's just going to keep propagating. And then we'll continue to move away from, the old school mentality of just destroying yourself and not being nice and polite, to a positive community that's healthy, ones that are collaborative, ones where M&Ms aren't a scary thing anymore, ones where we can truly move the field forward because we're working as a team instead of against each other. So that's what I have to say.
Thank you. I'm going to do a quick one from the 6-year-old that's sleeping upstairs from me right at this very moment. She's driving me nuts. She keeps telling me that, Mama, what you and Daddy do is too hard. It's so hard. It's the hardest thing to do, Mom. I want to do something easy. I have no idea what to do with this. So the parents on the panel, we're going to have a side discussion afterwards, but it's so simple and it's so obvious, but what we do is so hard. Even a 6-year-old can appreciate it. Yet somehow, because we've been trained for however long, and because we've been doing this for however long, we have this sick perception that somehow we have to be perfect at it when nobody's perfect at any field. And so we should just appreciate that every now and then. Doesn't mean we can't keep striving for perfection. Doesn't mean we can't keep trying to get better, or owning when it doesn't go right, or being disappointed in ourselves when we don't live up to our own expectations. But we definitely need to appreciate it a little bit more often, how hard it is to do what we do. So thanks, everybody. Have a great night.
Thank you so much. Dr. Coleman, you did an awesome job.
Yes.
Couldn't agree more.
Yeah.
Go
I didn't know how to
residents.
Zoom.
Excellent
She like
summary.
really made sure that all that was happening.
Hey, should we stop recording?
Oh yeah, please. Julianne, I don't know.